Good day, everyone, and welcome to our session today, Global Principles for the Measurement of Patient Safety. I'm Federico. I'm a Vice President at the Institute for Healthcare Improvement. And today's session, we have a panel discussion that's going to talk about the principles that we've developed at a Salzburg meeting about measurement for patient safety. We'll first start with welcoming you all and thank you all for being at the session. This is an exciting part. Yes, we are doing it virtually, and we are doing our best to share with you all the knowledge and experience we have, and we appreciate all of you for your attendance and participation at the forum. We start with our disclosures. None of the faculty here at this session today have any conflict of interest to disclose. Current systems of measurement in healthcare require lots of collection of data. Yet it's still difficult for us to determine whether or not we actually have safe systems, and that's a big challenge for us. So our thought was, could we find ways that instead of overwhelming staff with so much data collection, so many measures to then pick up and then analyze, that we could find a way to offer a streamlined opportunity to figure out which are the right measures that we need and how do we collect them quickly and easily. Our objectives are to describe the process that we used for the global principles that we developed, list those global principles, and discuss how you might apply those principles in your organization when you go back. The challenges are that there are no widely used measures for safety. There is the trigger tool that IHI has developed. There are others who have serious reportable events, others who have events reported from their reporting systems. So quite a few different ways to measure safety, but it always fails to detect all the instances of harm and errors that occur. There's a narrow definition of harm in many places. Our definition of harm is if the patient experienced it, then we must count it. And also many of the measures are so much focused on the acute care setting. That is, we don't have good measures to measure across the continuum of care about the patient's journey. The challenges are that in order to collect all of those measures that we need, we have to invest significant amount of resources. Time dedicated to those measurements is taken away from patient care, is taken away from quality improvement. The measures are generally retrospective and reactive. That is, we know what happened in the past, but it's hard for us to find a way to develop measures to tell us what is our risk for the future, what are the things that we need to be aware of. And of course, the interventions that we develop are the ones that we should be focusing on to be reactive. That is, I should say proactive, so that we are ahead of the curve. We're preventing the harm from happening in the very first place. Measurement should be used to inform about the current status of the system and the processes. It should be able to provide information on where we need to focus our improvement efforts. Oftentimes you will hear, where are the defects? How do you find those defects? How do the measures tell you that story? And we should use them to hold people accountable for results. Now, accountable also has a very negative connotation. We don't mean punishment, but we should be able to tell when someone or some part of the organization is not functioning the way it was designed to be functioning, that we're able to identify that and immediately go and determine what we can do to make it better. There are a number of folks who have been writing about the tyranny of metrics. This one in particular caught my attention. And the reality is we cannot measure everything. But we need to measure what's important to us. We need to figure out how to set goals by measures or by the desired outcomes. Because if we do it by measures, there are unintended consequences. That is, there's gaming of measures, there's just patient selection. We only choose those patients where we know there's the best outcome or the least amount of harm. Yet if we do it by outcomes, we're putting the patient at the center of what we do, which is really what this should be all about, because we are to care for the patient. The fallout or the things that could go wrong are highlighted in this book, The Rule of Nobody. If we think of the 4-hour emergency department rule in the National Health Service when it was first implemented, all very well intentioned, but what happened? There was gaming of the system in order to meet the 4-hour rule. The mid-staff offers another opportunity for us to look at how they use their mortality data. The 1-hour administration of antibiotics in community-acquired pneumonia resulted in overuse of antibiotics because people were not doing it for the best outcome. They were doing this to meet the mark of ensuring that we got the right antibiotic to the patient. Completion of the surgical checklist. Many studies have indicated that it becomes a tick box exercise rather than meeting the intent of the surgical checklist, which is to have everybody understanding what is it that we're doing today, what are the risks we're facing, who has the accountability. In Australia, in a nursing home, there was so much effort putting into collecting the measures to meet the guidelines that were set for these nursing homes that patients weren't getting the care. And some of the things they were doing were quite silly in what they were doing. And what the Australian government did in this particular example is they turned it back to the nursing home and said, this is how we define the quality of care for patients in the nursing home. You figure out what to do. And dropping all of the measures that they had to just those significant few, suddenly the quality went up for those patients. And also, teachers teaching to the test. We have many examples where, for example, in the United States, teachers are required to ensure that their students meet a particular test grade, but yet what they're doing is they're teaching the students how to pass the test rather than how to gain knowledge and learn. The overabundance, as I said, leads to the question of the validity of the measures, that we're focusing on the metrics and not doing what is correct for the patient. We have staff who are overworked and have to spend so much time analyzing all the data and yet may not even have the understanding of what the data are telling them. It is extra work for clinicians because we ask them to constantly have to document and do other things that they probably aren't really necessary to do. The usability of the appropriate audience is an issue because we collect and don't necessarily identify what is important to who that audience is. And there's always the increased cost that goes along with data collection. So I like to turn it around to say, what is the story that you want to tell and who do you want to tell that story to? Because that's what your measures should be doing. They should helping you design and put together a story that allows you to tell how well your organization is functioning, both for patients who need to know that and for the clinicians who are doing the work to provide good care. To do that, we have our panel today, and our panelists include Gary Kaplan. Gary is right now serving as the chairman and CEO of the Virginia Mason Health System at Seattle, and he's been there since 2000 in that title, in that role. He is also practicing internal medicine physician at Virginia Mason. Dr. Kaplan has served as chair of the Institute for Healthcare Improvement Board of Directors and is currently the chair of the IHI Lucian Leap Institute. Our next speaker will be Niek Klazinga. Niek is a medical doctor by training, professor of social medicine at the Academic Medical Center at the University of Amsterdam since 1999, and has been coordinating the healthcare quality indicator work of the OECD in Paris since 2017. Over the past 25 years, Niek has been involved in numerous projects and publications on quality in healthcare in the Netherlands and abroad. And we have Helen Haskell. Helen Haskell is president of the U.S. not-for-profit patient organization Mothers Against Medical Error, co-chair of the WHO Patients for Patient Safety Advisory Group, and a member of the IHI Board of Directors. Since the medical error death of her young son Louis in 2000, Helen has devoted herself to enhancing patient contribution to safety and quality in healthcare in a wide range of areas, including safety measurement and patient reporting. Gary, I turn it over to you.
Thank you, Frank, and good morning, everyone. It's morning here in Seattle, Washington, very early morning, and it's great to be with you this morning. As Frank told us, there are many, many challenges that we all experience with our current systems of measurement. I know that's been a challenge for me personally as the chief executive of a large health system in the United States. It's also a challenge in my role as chair of the Lucian Leap Institute, which is a think tank focused on moving the field of patient safety forward. It's these challenges that we've all experienced that really drove us to look at how we could come together to better understand, design, and coordinate systems of patient safety measurement around the globe. And it led to the Lucian Leap Institute's partnership with the Salzburg Global Seminar program. So as we think about this Salzburg Global Seminar, it was a chance for many of us to come together for 5 days, focused singularly on measurement and patient safety. Our objectives were to identify guiding principles for measuring patient safety, and it was a real experience for all of us, bringing some of the best ideas from around the world and diverse perspectives forward. I do want to mention that this effort was supported by an educational grant from Medtronic to the Lucian Leap Institute and the Gordon and Betty Moore Foundation that also supported this very important work. It was an endeavor that we were all energized by and proud of what we were able to produce. The Salzburg Global Seminar, for those of you who don't know about this, was founded as a not-for-profit in 1947. Its mission was to challenge current and future leaders to shape a better world. They bring together people from around the world for global conferences on topics, a wide variety of topics actually, bringing talent, different cultures, and different sectors to inspire new thinking and action in an environment that was really very conducive to trust, openness, and all of us sharing our very best thinking, our best ideas, and not ashamed to admit that where we had come from certainly was not optimizing measurement as far as we were able to take it. Just by way of background, the Lucian Leap Institute was actually formed in 2007. The goal was to provide a strategic vision for improving patient safety. Our membership has stayed stable and evolved. We've added new members, new ideas, new thinking, as several of our members have retired. But many of us have been part of the Lucian Leap Institute almost since the beginning. This think tank has generated white papers and really, I think, has helped make breakthroughs in our thinking around patient safety. That said, we certainly have a long ways to go, and this focus on measurement, we believe, is a critical step. We can't make the breakthroughs that we need to make if we have not made the progress and improvements in measurement that we work so hard on and that I'll share with you today. The Salzburg Global Seminar had 3 co-chairs, 2 of whom are here today. Frank introduced Helen and Niek, and Tejo Gandhi was our 3rd co-chair. Great leaders in safety and quality, and really helped guide us, because when you get as many people as we had, all type A personalities with their own ideas, I think organizing our efforts was a challenge, and our chairs did a fabulous job with this. We set out for ourselves goals for the seminar. We wanted to leave the seminar knowing that we had achieved our goals, and our objectives were to design innovative recommendations for how patient safety should be measured, while better acknowledging and codifying the challenges and opportunities. We continue to believe that we won't be able to make the breakthroughs that are necessary unless we are also willing to understand where we're falling short today. In addition, we developed global principles, principles that we think are meaningful for all stakeholders, regardless of where we work, where we practice, where we the cultures from which we come from, and they have universal application. We had 44 participants, 6 continents, 18 countries. That was quite a United Nations of safety and policy people. We had patients represented, actively represented. We had leaders in global policy. We had representatives of not-for-profits from different countries. We had leaders of agencies, leaders from the public sector, as well as leaders like myself from delivery systems who wanted to take and hope to be able to take the principles that were developed and begin to apply them in the field. We had clinicians, physicians, nurses, pharmacists, people who spend their time working in the community, and we had, as you would expect in a seminar of this type, we had researchers, people who are always thinking about what's the next question we need to ask. And you can see here the diversity in the group. You can recognize perhaps some old friends from your countries of origin, as well as many people that we've come to know in our IHI seminars over the last many years. So as a first step, we felt it was critical to identify the principles for patient safety. And this, was not a no-brainer. It wasn't like just list them on a flip chart and there we have them. It took considerable work and several iterations and a lot of back and forth, which I think helped us get to a better place. When you get diversity of ideas and diversity of thought, it can hold you it can keep you from making progress, or it can be leveraged to get a better quality outcome. And I believe that's what happened at Salzburg. We issued a Salzburg Statement on patient safety, which is available, and you can find links to both our global principles and the Salzburg Statement on the final slide of the slide deck. We also said, it's one thing to articulate the principles, to put out a statement that people can use as a touchstone or as a guidepost, but what we really need to do is translate this to action. And it's interesting, following the seminar, as we convened the Lucian Leap Institute membership, many were becoming increasingly impatient with the notion of being a think tank alone. I mean, what is it that a think tank does? It generates ideas, but those ideas are only effective if we're able to translate them into action in the field. And so that's was a major area of focus, and that's a work in progress as we speak. We also, as I said, made many new friends. Many of us have stayed connected and continue to share ideas intermittently. In some ways, COVID kept us from coming to Copenhagen, keeps us from coming to face-to-face meetings, but in some ways, the remote learning and the ability to use remote platforms has actually connected us perhaps in a deeper, more ongoing, real-time way than we were able to do in the past. So as we think about the global principles for safety measurement, I'd like to review these with you briefly. The first is the purpose. The purpose of measurement is to collect and disseminate knowledge that results in action and improvement. So to follow up on my prior comments, again, if we don't translate what it is that we come up with into action, if we don't use the measurements for improvement in the field and to be actionable measurements, then they really don't have the value for us. And those measures must feed into a learning system so that we can continue to make improvements, measure, and continue to drive even harder on the improvements. The second principle, effective measurement, requires the full involvement of patients, families, and communities within and across the health system. I mean, why are we here? We're not here to generate more research papers. We're not here to populate think tanks or to put in place global principles. We're here to serve our patients, their families, and our community. And so by engaging them in the design and the usage of effective measurement, we are able to make it come alive at the front lines. Engaging patients and families in so-called co-design is critical, and we have one of our key principles, as you see here, is that this engagement, this involvement of patient families and communities will be critical to design of the metrics that will be that will allow us to truly be patient-centered and and to be transparent with those we serve as to how we are actually doing in keeping them safe. Safety measurement must advance equitable care. Equity, the absence of avoidable, unfair, or remediable differences among groups of people must be a consideration. I know in the United States, health equity has never been more important and never been more on the minds of those of us who are delivering care on the front lines. And the Salzburg attendees believe that must be part and parcel of our agenda. And the fourth key principle, selected measures must illuminate an integrated view of the health system across the continuum of care and the entire continuum and the entire trajectory of the patient's health journey. This was an interesting concept, interesting discussion. So much of our measurement to date has been in the acute care setting. So much of our safety improvement work has been in the acute care setting. But as we well know, patients spend very little of their time in the hospital. How do we apply measurement of patient safety in the ambulatory setting, in our clinics, but also in the home setting? We are seeing more and more disruptive innovation that is taking care that used to be in the hospital to the ambulatory setting and subsequently to the home setting. And so we need to ensure that our measures reflect the entire continuum. The final four of the 8 measures, final 4 principles, data should be collected and analyzed in real time to proactively identify and prevent harm as often as possible. You know, so much of our data is delayed and is after the fact. I often talk about retrospective quality assurance as opposed to embedding quality and safety as a principle of the process so that you can actually create real-time quality assurance. And we believed, as we designed these principles, that we needed to every extent possible, collect, analyze, and report data as close to real time as possible. That's going to allow us to identify and prevent harm. That's going to allow us to be much more proactive. Next principle, measurement systems, evidence, and practices must continually evolve and adapt. You know, we knew that, all of us believed in learning systems and being part of learning organizations with learning cultures. And one of the characteristics of those cultures, those systems, is that we evolve, that the environment, the fund of knowledge, and the context of care changes. And that likewise, we believe measurement systems will need to change as the evidence and as how we use those measurements evolve as well. The burden of measures collected and analyzed must be significantly reduced. This was a big one, particularly for delivery systems, where like I lead, the burden of measurement is on our people to collect the data, to analyze the data. And how can we simplify the measuring systems so that the burden is mitigated, that it's something that is easy to do, that if we want to measure in real time, we have to make it easier to obtain the data and then to analyze the data and reduce the burden of measurement, or we won't have the support of the people we need to actually implement and operationalize this data for improvement and change in improving the health and well-being of the people we serve. And finally, stakeholders must intentionally foster a culture that is safe and just to fully optimize the value of measurement. That's all about the context. That's about where we're applying this data, this information. And we need to work on ensuring just cultures, that we can have the best safety practices that are available in the world, in our organizations. But if we have a fear-based culture, if we have a culture that is not what we would call a just culture, we're not going to truly be able to make the kind of improvements and have them stick and be sustainable over time. The last subject I want to briefly talk about is the leader's role. It's something, that I think about a lot. As a leader, as a senior leader, I've been involved in leadership for most of my career over the last 40 years. And I've come to realize how critical the role of leaders are in both setting the tone and the culture of organizations, but also leading the way forward to change. And if we change our measurement paradigms and our approach to measurement for safety, that's not something that's going to be necessarily totally embraced. So, leaders. Leaders have been focused on receiving information, but what is it we do with that information? These are some of the receivers of the data. If we're able to collect real-time, actionable measures to propel us forward, these are the really the stakeholders that will need to receive that data and then incorporate that data into their work and their processes. Regulatory and accreditation bodies, hospital and organizational leaders like myself, clinical leaders and clinicians who are on the front lines of delivering care, nurses, physicians, pharmacists, those who are at the so-called sharp end of care, the people who deliver care, patients and families certainly, and our payers. Depending on how our various systems are financed, how the payers think about quality and safety will be critically important as well. So these measures that I as a leader need to embrace and receive and take action on, these are the characteristics that we identified as critically important. The data needs to be meaningful. It must evaluate something that's important to measure, and the value of that measurement must be available to the key stakeholders of the processes that are being measured. They must be valid, scientifically acceptable. Is it as evidence-based? And has it actually been tested? Feasible. We could set out to measure all kinds of things, but if we can't actually collect the information on a close to real-time proactive basis, then I think we're talking about workarounds, data that does not really reflect what it is we need to measure, and a very heavy burden on the people we depend on for collecting them and analyzing the information. It needs to be fit for purpose, meaning it has to be actionable and designed to add value for the specific purpose or the stakeholder that needs the data and wants the data in order to affect the kind of action that's necessary to keep our patients even safer. And finally, it needs to be reliable, that the information in data is easy to understand, but that also it's reproducible, it's consistent across individuals and settings. And so these are the characteristics we identified as the critical characteristics of effective measures. So senior leaders, people like me, we need to use this information, these measures, to understand if we're safe or not. As an organization, as a service line, as a department, we need to understand what it's telling us about our organization or about systems within our organization. We can use this measurement to understand and evaluate the culture in our organization. At Virginia Mason here in Seattle, we do a culture of safety survey every year. It gives us actionable information. I don't always like everything I see or I hear, but without that information, I can't know where the opportunities are for improvement. We need to use the information to ensure the safety of our workforce. When we talk about the entire continuum of care, it also includes the healthcare workforce, not just those we serve. Because if our team members are not safe, both physically and psychologically safe, then we're not going to be able to optimize safety for the people we serve. Senior leaders use the measures to set a vision and a strategy for patient safety. We can understand where we are strong, where we are weak, what we need to work on, what we need to keep working on. I've used the measurements we have, as flawed as they've been and as hopefully old as they will be as we develop new measures, to help us design our strategy and tactics around patient safety. And then finally, we need to use these measures to help us evaluate, are we doing what we say we're going to be doing? Are we making the necessary progress? So just a few thoughts on the role of the CEO or the chief executive in an organization. And as I've said, it's our responsibility as chief executives to set the vision and the strategy for patient safety. We can't delegate it. I think where we sometimes fall flat in organizations is where we, as the most senior leader in the organization, don't take ownership of important bodies of work. Like nothing is more important than keeping our patients and our team members safe. And so we have to own it. We have to set that vision and strategy as we go forward. Part of doing that is ensuring that we have core metrics to monitor on our strategy and tactics. If we don't measure it, we're not valuing it. And if we can't measure it, we don't know if we're having an impact, if we're making improvements, or if we're sliding in the wrong direction. Measurement needs to help us ensure that we have evidence-based practices embedded in our safety strategies. Measurement allows us to ensure that we can, with confidence, engage in public reporting. And so one of the things that's been challenging for many organizations and for senior leaders like myself is the transparency that's required to truly ensure public reporting is available to our patients, their families, our employers who pay a lot of the bills in the United States, and those who are watching us, the regulators, the public sector. It's a dimension of transparency that's critically important that we have to embrace as senior leaders. As senior leaders, we need to adopt information systems that support our safety measurement and hopefully reduce the burden of collecting and analyzing that data. And then finally, we need to encourage our team members. We need to activate our workforce to ensure that we are constantly involved in improvement, and we are engaging with others outside our organization who have a common interest so that we can continue to learn together. All of those things really fall on the senior leaders of organizations, and I know many are on this at this presentation for going forward. And then finally, I just want to mention a couple words about governance. Governance, it takes different forms in different countries. But here in the United States and in many organizations, in many countries, governance is a critical role. Governance is what we call our board of directors. In our case, they're from leaders in the community, from companies like Boeing and Starbucks, Microsoft, who really hold our organizations in trust for the community. My boss. And frankly, I think governance is one of the most under-leveraged levers we have to advance our patient safety agenda. And it's now said that best practice governance means that safety metrics are available to the board at every meeting. And the board needs to explicitly accept responsibility for quality and safety. I remember almost 20 years ago when I told my board as a new CEO, by the way, you're responsible for quality and safety. You need to hold us accountable. You need to ensure that we have the metrics that are required for you to understand how we're doing and for all of us to understand how we're doing and to move forward and make progress. You need to have unfettered access to patients. And at Virginia Mason, interestingly, as some of you know, we start every board meeting with a patient story, but with the patient in the room. So it's anxiety producing for management, but our board has said we don't want good stories. We want to hear patient experiences where they had identified opportunities to be better, unfiltered access to patients. And finally, it's critical that our boards, our governance functions, prioritize safety measurement as they have their key responsibility, which is to recruit, hire, and potentially even fire their CEOs. The safety agenda needs to be part of the criteria by which people choose to bring a new CEO and ensure that that CEO is held accountable. So Salzburg was a great experience. The practices, I hope, will be very helpful to you, and the principles, and just a few reflections on leadership, and I'll look forward to our discussion period. Thank you very much. Turn it over to the next.
Great, Gary. Thank you. Niek, would you please step up next?
Good afternoon, everybody, and thank you for the opportunity also to share from the perspective of the Organization for Economic Cooperation and Development how the global principles that were developed in Salzburg can apply in practice. It was a pleasure to participate in the meeting in Salzburg, and I think the 8 global principles cover far more than just the literal text. They try to communicate a strategy and an approach towards patient safety worldwide. And what I would like to share with you is basically how an organization like the OECD is handling it at the moment, and how it aligns with our thinking. What you see here is a slide that summarizes some of the work that the OECD has been involved in the past years. And it addresses also leaders, but leaders of whole countries. A lot of our work is aimed at the Global Safety Summit, which is a regular meeting of ministers of health where they discuss the patient safety issues. It started in London, afterwards in Bonn, Tokyo, Jeddah, and the Global Safety Summit this year was planned to be in Switzerland, but had to be postponed because of Corona. But the debate is ongoing. It's one of the places where ministers of health meet, and a focused discussion takes place on the importance of patient safety. Another such a forum is the G20, very economic oriented, but since this year, under the presidency of Saudi Arabia, patient safety has become one of the focal topics when discussing the performance of healthcare systems. So it's in these fora that the OECD tries to bring in ideas and notions about safety measurement. And it has been doing that also in its global publications, such as Health at a Glance, where since 10 years we publishing international comparative measures on patient safety. I just have a list of reports here that came out. A 2017 report looked at the economics of patient safety. There we really try to make the point that it's also a good and sound way of stimulating your economy to invest in the prevention of safety and shift the costs of failure towards investments in prevention. We shifted in 2018 by emphasizing the importance of looking at patient safety in primary care and ambulatory care. You see a similar report which was released in this year in September, but was prepared for the Global Summit in Switzerland, which focuses only on long-term care, how to value long-term care in how safety and long-term care, but also what are the economic consequences. A report on system governance, which looks at the governance mechanisms towards safety. A report on culture, which gives an overview of the various international attempts to assess culture. And recently, in bold here, a report that was released 2 weeks ago as it's supporting the G20 in analyzing further how investments in economy should be combined with investments in safety and in healthcare. This is not the focus of the rest of my presentation, but I just want you to be aware, yes, there is global leadership. There are ministers and prime ministers who pick up the topic, and we try to feed this action with intelligence, including the global principles that were developed in Salzburg. Because in all of these reports, there is a perspective where the OECD tries to align what is happening on the clinical level with patient safety, thinking about infection prevention, venous thrombosis, embolus, falls prevention, how that links to the overall organizational perspective. And then it's linked to the digital technology, the staffing, the culture, patient engagement and transitions of care, and how these organizations like Virginia Mason, where Gary just spoke about, is linked to the overall organization of healthcare systems. What are the levels of accountability? What is the governance and knowledge, and how is safety built in the education and training? And very important, how are incentives in the system aligned towards improving safety? So when I pick one of the principles, the purpose of measurement is to collect and disseminate knowledge that results in action and improvement. From a system perspective and in reports of the OECD, that means that safety measurement should be should be embedded in national and regional data infrastructures and governance, and should be aimed at learning. That sounds very grand, but in essence, it has a lot of practical consequences. It means, for example, that there should be alignment and cascading of the safety measurement and the data that are used for that between the clinical level, the institutional level, and the health system level. That has to do with the architecture of your data systems. And also in the governance approaches, there should be alignment between the summative and the formative ways, meaning how do you balance accountability with learning? Because at the end of the day, the measurement should contribute to continuous learning. And that means if you, for example, totally separate the two and you have separate clinical safety quality improvement initiatives that are totally not aligned with the reporting obligations to an inspectorate, then there is no synergy. So this general principle has a lot of consequences in the way how you look at governance and data infrastructure in healthcare systems. Another principle, effective measurement requires the full involvement of patients, families, and communities within and across the health system. This is reflected in how the OECD tries to broaden the safety measurements to different areas. So I told you we publish data on patient safety indicators, mainly modeled after the ARC indicators in health at a glance, trying to compare the administrative databases, and there's a lot of technical work going in comparing the coding systems and how to get the data out of the administrative data systems. That's what we started 10 years ago, but in the past 3 years, you see more and more work on patient-reported safety measures, actually a program supported by the EU, and our recent work on safety culture measurement, where with about 10 countries, we have groups of institutions that measure with the same instrument safety culture to get some cross-country learning. And more recently, we started focusing on the safety of healthcare workers. As you might be aware, that was also the focus of the last World Day on Patient Safety, 17th of September, led by the World Health Organization. And yes, the work of on the worker safety has been a prominent part of that. When we look at another principle, data should be collected and analyzed in real time. Measurement system, evidence, and practice must continue to evolve, and the burden of measures collected and analyzed must be significantly reduced. It really boils down to the overall policies on strengthening health data infrastructure in countries. And that has to do with the linkage between registries, administrative data, how the whole electronic health record system is set up, survey data, and last but surely not least, the positioning of patient-reported outcomes and data and experience data. PROMs and PREMs are collected worldwide, but are not built into the data structures. What we try to do in advising countries on different measurement efforts to make sure that all safety-related measures are embedded in this broader picture. So to conclude, stakeholders must intentionally foster a culture that is safe and just to fully optimize the value of measurements. One of the other Salzburg principles, this means that you have to connect the stakeholders, and what you see in this figure is that, again, from a system perspective, you try to align the activities that are taking place on a clinical level. You see them here again, the classical safety issues, and we try to broaden that to other settings. As I said, clinical should also be applied in long-term care and in primary care. but it's linked to the data infrastructure and it's linked to the organizational structure. And those are linked to some fundamentals of your healthcare systems, such as the professional education and training, public reporting on safety and outcomes, and to the extent that on a national level there are safety standards and national theme-based strategy. But that's all encaptured in a culture. And a culture is something that is really driven by the leaders that really put it on the agenda. That brings me to my final slide. What we've seen in the past 6 months is that it is possible to mobilize a lot of governments, providers, and citizens for an issue. When you look at the way how countries have responded to the COVID-19 pandemic, it demonstrates that governments act to protect the public and the economy. So on this topic, COVID, the action is there. Resources can be mobilized to quickly and effectively. Behaviors can be changed, not shaking hands and keeping distance. And governance and health systems can work in concert across silos. So reform is possible with the right will and urgency. Please keep in mind that the total number of deaths that are related to patient safety issues is comparable what we see with COVID. So consider for yourself, how can we really capitalize the momentum? Can we take the global principles of Salzburg and try to use the action that is taking place in our healthcare systems, notably in the way how we collect data, share data, and learn from that, and make sure that we capture the moment and build patient safety in our systems. Thank you for your attention, and happy to respond to any questions that might have arisen.
Thank you, Niek. Helen, would you wrap us up for today? Good. Helen? We can't hear you. You may be muted. Is your microphone on?
Oh,
There we go.
thank you, Frank. My apologies. I hit the button and it didn't work the first time. So welcome everybody, and thank you for coming. I just wanted to sort of continue on the theme of the emphasis on patient and family that you heard from both Gary and Niek. I am a patient advocate, and I was gratified that one of the main messages we took away from our time in Salzburg was the widening recognition of the centrality of the voice of the patient family. The idea that the overarching goal of measurement is really the significance of the medical encounter in the life and health of the patient, and that almost everything else is a means to that end, one way or another. So to get at the information, we need to do this in a clear, focused way. We need to think about restructuring the way we've been looking at measurement and the ways that patients, families, and communities have been involved in it. Let's see if I can. Okay. So very early in the Salzburg Seminar, the team that was tasked with patient engagement brought back to the group, among other things, these 3 old chestnuts, which rapidly became part of the DNA of our deliberations. So they're about justice and parity, nothing about me without me, which in various renditions has been a rallying cry for democracy since at least the 16th century. They're about focus and goals, what matters to you, and about perspective through the patient's eyes. 3 fundamental attributes that need to be part of any measurement. So why specifically do we need patient-centered measurement? Fundamentally, it's because of the patient's unique viewpoint. Healthcare providers come and go in the patient's life, even in the hospital. Patients and families travel across the entire healthcare system, including the gaps, the synapses between providers. Most providers only see their part of it. Patients bring fresh eyes to practices that providers may have become habituated to, and they know intimately what the final outcome has been for that patient, something that is often not fully captured in measurement or even in medical records. This quote from another context from one of our participants sort of captures the essence of it, I think. The answers you get depend on the questions you ask. We've been asking questions for the patient and about the patient while ignoring the treasure trove of information that's available from the patient. So what are we trying to achieve? I think the potential is really exciting. The patient voice adds the prospect of taking safety and quality measurement to a new level, to using it to look at the value of interventions by seeing what the long-term outcomes are for patients and looking at what ultimately provides the value that patients are looking for, really looking at the purpose of healthcare. So what makes a measure patient-centered? There are a lot of attributes. They don't all apply to all measures, and some apply to measurement in general. I'll just go through these quickly. Probably the most important is the direct patient voice, which should include the family and carers, especially in instances where the patient has died or is unable to respond. That's information we often don't capture now. In general, we just want to broaden the net, provide a variety of formats going across the continuum, forward in time and backward toward the present, so people can use measures readily for decision making, and even within institutions for intervention in real time. Narrative data, qualitative and quantitative. Narrative data I have found in years of working on patient reporting is really essential for capturing both the arc and the granularity of a patient's experience in ways that other methods just can't do. So patient contributions can be both comprehensive and wide-ranging via multiple pathways, about multiple aspects of the system, and throughout the measurement process. Again, reporting on things that, and thinking about things that are not necessarily top of mind for caregivers. Equity is a critical aspect of patient-centered measurement, because it really is about making sure that the needs of individual patients and patient populations are met. But what makes measurement equitable? Ideally, measures are developed to apply across all settings and population groups, and at the same time to record demographic and geographic data in a way that reflects disparities in needs, resources, and care. This is a challenge, although people are certainly working on it. Measures also need to be developed that are specific to different settings and groups. And again, this can't be done without including the relevant populations, including people of diverse backgrounds in measure development, to help ensure that the questions asked are both culturally and operationally relevant for the populations they're aimed at. So what's the first rule for engaging patients in measurement? Make it easy. We need to make full use of available technology, including the EMR, the patient portals, and smartphones. People around the world use texting to communicate, for example. It's an underused resource in healthcare. Measuring health literacy and knowledge so you can know best how to format questions and find out where the educational gaps are, where the opportunities lie. And using electronic data capture, bringing together data from a variety of sources, including things like patient complaints and incident reports and medical records. There are many ways to bring people into the measurement process. You can recruit patients to help determine both what to measure and how to do it, adding safety, quality, and outcomes questions to patient experience and surveys and prompts that are existing and provide a great structure to build on. There's still important aspects of safety that these measures do not get at. Solicit feedback about your system, measure the response of the system to patient input, and make the results transparent. This isn't something institutions have found easy to do, but it is probably our biggest driver for improvement. And finally, there's the community, another often underused resource. This is how you tie measurement into your local healthcare system. Through awareness raising, making people aware of what they should expect from healthcare and how it's measured, and through education, filling in the gaps that may be exposed by measurement. In some African countries, community involvement has been taken further with community healthcare boards and scorecards on performance of local hospitals. But however you do it, measuring locally helps mold a system that meets the needs of the community. So we need to keep the end in mind. Measurement is not the point. Learning is. This is from Niek Klazinga, whom you've just heard from. I've just learned that his name is pronounced a different way than I've thought all these years. But the point of measurement is learning, and the point of learning is improvement. So measure for reasons that matter to patients and act on your finding. Because the aim of measurement is learning, improvement, and as odd as it may sound, increased happiness. The goal of measurement is to make life better for all of us. And I will turn it back to you, Frank.
Thank you, Helen. And if the panelists would all turn on their cameras, we'll take the slides off. There was a lot of activity in the conversations, and common themes that seem to have come out were, so we have these principles, and Niek, you sort of developed a little bit of a diagram showing how do we get all the stakeholders to adopt these principles, not just the healthcare system. How do we go to government? And you mentioned something about what have we learned during COVID. Any suggestions and any experience, Gary, you have, or Helen, you have, about how do you get other stakeholders to apply these principles as well?
I think it starts with convening. It starts with kind of having the conversation. And, COVID taught us a lot. I had more interaction with the public sector, with the government, the public health departments, and my competitor CEOs in our region than I'd in the past 6 months than I'd had in the past 20 years. And so I think it shouldn't take a crisis. It shouldn't take COVID, but we have to find venues to bring people together and to help educate and drive engagement. And I think that's where it starts. And I think this was a step forward. It's why we had people from the public sector as well as the private sector and as part of Salzburg. But I think it's going to take new ways of working together for us to address this issue.
Helen, anything to add to that?
No, that's interesting perspective. I mean, from the patient perspective of patients and patient advocates, COVID has been alarming, not just as a disease, but the fact that patients and families have been excluded and can't help their loved ones who are in nursing homes or hospitals and don't know what's going on there and are not able to measure in their own way. And the fact that some measurement was suspended, all of that has sort of raised huge red flags to us, big concerns. And I don't know that we have solutions yet. We are just trying to get back into the healthcare facilities.
Great. So we're almost at the end of time, and there are so many people that have commented on, we want to test, we want to participate, we want to contribute this. What we have to do is develop that mechanism to do that. And until we actually publish the final version of our work, I think it'll be difficult to really understand, because that document will have a lot more detail. However, in the meantime, and there were so many other questions, I offer you my name as a contact person, and we can actually follow up on your questions. And my email address is F as in Frank, Federico, so FFEDERICO @ihi.org. And if you don't remember that, just go to ihi.org, put in my last name, and you will be able to find me as well. Thank you to our panelists. Great session. You built on each other wonderfully to bring us to this end point of where we need to go with measurement in the future. Much appreciated, and our audience likewise is being very appreciative of all that you've offered. Thank you.
Thanks.
Thank you very much. Have a great conference.
Bye-bye.